Mexico can go. Then you have the process biology, a lot in the market now. Maybe the one that comes to my mind now is Matroderm, for example. Like Matroderm is process biology, and then the synthetic method integral, if you remember. Yeah.
Very precious.
But they provide a scaffold for new derms to protect from infection, reduce shear, and can handle a large or complex effects. So they help us. We believe in that they provide the necessary matrix for the collagen to come and do the healing. Cost is a big problem, and these. Very quickly, best pros and cons of how to do them. I don't think we need to go into that. But we need to know when we get a biologic dressing, it's like a transplant, there's a risk of, like a blood transfusion, it's a biologic, there is a risk of infection. You can transmit viral infection, that's a problem with them. And the availability, of course, you cannot have all these donors, it's not easy. The processed ones are very good. The cost is very high, but we have huge number of companies that provide that, and they're very useful, except they are expensive. For example, one big benefit of these processes, like covering of tendons and bones. Now we start using that a lot because when you put a skin graft on a bone or a tendon, it doesn't heal as much. We use dermal mattresses that helps us to avoid problems with the skin adhering to tendons and bones. And synthetic, there are many types. I'm not going to bother with this. This is one quick thing. This is one patient we did. Matrix was one of the companies, but I didn't want to show the name. But many companies in the market, they're all good. So that's, I hope it's clear. So that's the defect. You have a little bit of the tendon exposed there. We use to help the patient a Matroderm and then a skin graft on top. So the process, just to tell you how to use technology with your surgical skills to get the best possible results. But then skin grafts, they're either split thickness or full thickness skin grafts, and they are good, they're quick to do, morbidity is not huge, طبعا donor side, but they don't look good, long term they're not good. I'll show you one patient just to have an idea of how things go. هنا, this patient is a hematoma wound, you clean, debridement to reach a, طبعا here we did back to this patient, that's one thing we do now, and this graft, immediate graft after 3 months. So just to show you tissue expansion and local tissue rearrangement. Again, this is one good way of dealing with wound defects. Tissue expansion, these are inflatable device placed under the skin. So you all have ideas about these tissue expanders. You've seen them in the hospital. So no. So yeah, I mean they're material like silicone implant, but we put them under the skin next to the wound, and we expand the skin so we have more material, more skin. Then bring them again to the operating room. Exactly. We inflate gradually over maybe 2 or 3 months. We reach a good amount of skin. Then we take the patient back to the operating room. We use the same skin to cover scars, old scars and all that. It's like this, exactly. This patient has a scar from old graft. This is an old graft. This I'm doing right now. We're expanding her slowly. So at the end, I can excise this ugly scar and just put her skin over. And this is a patient is as well for this burn scar. You can use the expanders even for alopecia, for example. We use alopecia, which is loss of hair, for example, in the scalp. We use it for wounds and other things as well. So that's the concept of expander. بعدين local tissue rearrangement, that's what we just talked about, the local flaps. The local flaps, if I have a defect in the nose or whatever in the body, for example, through moving the tissue around, you could reach, you could have a closure, and there are many of them, Z-Plus, CDY flaps, Uh, Let me show you one patient. For example, this patient, this is a cancer patient, right? So we remove the cancer, the defect is there. Now you want to close this defect, you have choice. Either should I put a skin graft? Skin graft doesn't look good. It will have colors around it. The best thing is to try to move the tissue around because it's the same color, it's the same consistency. Then you move the tissue around and you can reach a closure like that. After long term, she's gonna heal. The scar will be not visible, and she will have her hair because if you put a skin graft here, there is no hair. So that's the concept of local tissue rearrangement. This is again another guy. You know, he's got the cancer in his nose. And cancer, we deal with it like wounds. Now it's a defect. It's a wound. You clean it. You make sure it's clean, and then you close it. Whatever. This is you move the. This is called the nasolabial flap. We move it around. It looks good at the end, you know, after a while. It looks good. Better than a skin graft. If we put a skin graft here, so you think about it, you think about the patient and what does he really need? Does she care about cosmetics? Maybe not. Comorbidities, sick, older patients, you want to do the smallest minimum. You don't want to take long time. These patients take longer time. You know, so a lot of things about how do you, one size doesn't fit all, or how to individualize your treatment based on the patient's needs and morbidities. أخيرا الفلابs اللي I just told you about it. Flaps can be muscle, fascia, perforator flaps, a lot of types of flaps. You know, could use based on the blood supply. You could use your rectus abdominis, you could use latissimus dorsi, you could use your ALT to take it either pedicled or free. When we say free, يعني you actually take it out completely, you plug it somewhere else and you connect the blood vessels. Sometimes you leave it attached if you can and it's close by. But most of the time, feed defects, especially the lower extremities. Show you this one. This one we worked on for long. Yeah, I mean, this one is, will this wound heal? Never, right? Even you cannot. You put a vac, you put whatever you put, it's not going to heal. All the technology, the new technology, and the pressure, it's difficult. The bone exposed. Either you amputate or you do a surgery at the end. So we did a free flap for this patient. That's him, like that's on the table. But after a while, it looks good, and he can walk on his foot. So again, this all emphasize the collaboration between the different disciplines. Sometimes the patient goes and continue dressing, and for months, coast, the absences, sick leaves, and all that. Maybe surgery is a better choice for him. So discussions always is important between the different disciplines, surgeons and all the wound care specialists here. So you talked about hyperbaric. I'm sure other people talked about it. It's a very good modality, hyperbaric oxygen. The problem is it's not available. It's just not available. It's not. It's expensive and it's not available. But we know it increases oxygen. Now we know, like there are other dressings that have increased the oxygen, right? You have
the spray.
Yeah, the spray, and there is another one, I think.
Topical oxygen therapy.
Yeah. But we know oxygen helps with the healing. So different mechanisms of action and improve tissue survival. Studies, and I just wanted to show you some studies about that. The strongest evidence for hyperbaric oxygen therapy is with diabetic foot. The rest are not very strong evidence. There is benefit, يعني pressure ulcer, venous stasis, and all these. Some evidence, but it's not as the diabetic foot ulcer. It's not available. احنا عندنا واحد في العسكري، في واحد في الجبيل. في البحرين في واحد، في private في البحرين. It's a good modality to think about. And again, يعني you have always to choose the most easy for the patient, his budget, his work environment, and all that. الهايبرباريك.
بس يعني concentrate على الديفيد وحتى في بارت السكن.
Yeah.
another modality الحين
Yeah.
سايكوسمي ما
Yeah.
موجود. بس الهايبرباريك ماشينز هذه ما هي موجودة.
وهذه الissue دائما with whenever they want to make it smaller, how much concentration you actually can produce as effective concentration. طيب يعني هنا just the key factors, clinical appraisal of wound characteristics. That you all know. So you have to really look at the wound, examine the wound properly, see infected, not infected size and all that location. For us as surgeon, we look at donor site availability before we choose a flap, and then patient-specific issues here are very important. These we have really spent some time on. No matter what you do, whether dressing or surgery, if the patient is not okay, he's not going to heal. And we have many examples at Rosahla Hospital. We do graft, the graft is lost. We do dressing is lost. We put matroderm is lost because he's not good. He's infected. You have to clean him first. You have to get proper tissue perfusion. Say if he's cardiac patient and he has cardiac failure, there is no tissue perfusion, or vascular patient, it's very difficult to get what you want as a result. So you have to assess the patient nutritional status, metabolic disorder like diabetes. Diabetes is very, very bad for wounds, especially when you do surgeries with the patient hyperglycemic at that time in the operating room. It's very, it affects fibroblast, by the way, diabetes. Nutritional status, and when you, as wound specialist, you need to order this, but you need to be able to order these tests. Yeah, whenever you have a patient that's not really doing well, not healing as you expect, there must be something else happening. And I think this is an issue in our clinics. The wound care specialists, they don't order bloods مثلا, or they don't, and they should be upgraded to actually have, you have all these abilities to do care for your patient. Endocrine abnormalities are very important. Smoking, big problem with wound healing. And, if the patient doesn't stop smoking, you keep telling him stop smoking. If he doesn't heal, then means it's an issue. It's a big issue. Corticosteroids, if you see a patient who is actively on corticosteroids, So yeah, steroids are very important. So if the patient comes to your clinic and he's on steroid, you should try to see if you can actually stop the steroid temporarily. But if chemotherapy again and radiation, they all affect your wound healing big time. Summary: surgeon should integrate all available techniques. Can I just say I'll just do surgery? No, you integrate your back therapy, your dermal substitute, your advanced wound healing before you go for surgery. And then you have to actually improve patient factors, nutrition, comorbidities, to optimize your outcome. One size does not fit all. Each wound requires an individualized plan, drawing with the reconstructive elevator concept. Evidence-based wound closure relies on a thorough evaluation, both the wound and the patient, for overall result. And properly selected techniques and appropriate adjunct lead to successful functionally and aesthetic outcome. Now quickly, I'll just go over PRP. This can be. طيب. Platelets in wound healing. This is a normal platelet count. It contains alpha granules loaded with more than 30 bioactive proteins, and that's what transforming growth factor, epidermal growth factor, platelet growth factor, vascular endothelial growth factor. Name it. You can't memorize it, بس ممكن في ولا 20-30 واحد. They activate, they trigger, activation of the platelets will trigger a degranulation, and this will release the factors. Okay? When you release the factors, you get what we talked about it, and this helps the hemostasis and then the inflammation and remodeling. الissue just a concept مهمة نفهمها. Skin heals with scarring, but other parts of the body doesn't heal with scarring. And that's why we have to study this. The bone, for example, you have a fractured bone. The same process happens: hemostasis, inflammation, proliferation, and remodeling. But it doesn't heal with scarring. It heals with complete bone healing, and other tissues in the body to mucosa. But skin, for a reason, it heals with scarring, and that's our biggest problem. This is quickly, but just what platelets do. The tissue injuries that happens, the platelet will aggregate, then we'll do the hemostasis, clot formation. And hemostasis happens through intrinsic and extrinsic pathway. Following that activation, the clot will retract, vasoconstriction will happen, and then these factors will be released: PDGF, TGF, and other ones. Extracellular matrix deposition. We start the process of proliferation and then remodeling. Finally, tissue will heal either with scar or without scar. Skin always heals with scar. Even if you close them, primary closure, there will be a scar. So, platelet-rich plasma is a plasma fraction with platelet concentration above baseline. These are important concepts if you're going to start using the PRP in treatments of wounds. It has to be 3 to 5 times higher. And the concentration of the platelets in your it should be 3 to 5 times higher than the normal concentration for the efficiency. And this will have all these growth factors. They can use them as either you inject them, or use them as fibrin glue, or we call it platelet plug. The platelet activation will produce the growth factors, and then the potential benefit. It will help with faster healing, reduce infection risk, and improve the tissue quality. A technique, the way we do it is typically is a blood draw. A question is: wound care specialists, they are allowed to draw blood? Yeah. Huh? لا بس هم they need nurses for a long time. They're not nurses anymore. They're wound care specialists. But you are allowed, as privileged as okay. Do you do it? Do you guys do it? Anyone? يمكن 20 سنة. You still have the skill? Yeah. Good. So what we do is we get someone to draw blood, and you have to have at least 10 to 60 cc of blood, okay? بعدين the centrifuging, and that's the trick. The centrifuging, if you work with this, the companies will come to you at this step. Companies, كل company عندها a different machine. They will like Magellan, Symphony, many machines في الماركت موجودة. The fight between the machines, it tells you, and I give you 5-fold concentration of platelets, ولا 3 ولا 2. Following that, if you transfuse هذا I'll show you the picture أحسن. أنت تكلمتي عنها قبل شوي برضه, بس let me go into details. That's what happens. You get the blood, بعدين you put it in a centrifuge. Centrifuge, we'll centrifuge it. عادة نسمي first spin for 15 minutes. There are some other protocols. Some people do it for 10, different protocols. This will separate the blood. This is plasma, well, that's RBCs. In the middle, what do we call that? أحد ذكر هذا الأبيض اللي بالوسط. Buffy coat. It's called the Buffy coat. وهو اللي فيه ال platelets and WBCs عادة. It's not pure platelet. It's the Buffy coat. Then some people will just use that right away, like you mentioned, but it's better to do a second spin, which is called the soft spin, to isolate the platelets even more. هنا يطلع لك اللي هو ال PRP. And then you take it either in a syringe and you inject in the wound, well, some people use it, like I told you, it's already made fibrin glue and things like that. So the recommendation is 3 to 5-fold baseline concentration. There is no ideal concentration guaranteed. You can never tell how much concentration you have in that syringe, you know. لأنه مرات أصلا you break down the platelets and all that while you're doing it. People studied that يعني with this machine and that machine. إيش يسووا يعني استخدموا ال PRP هذا وحطوه في الanalysis for studies يعني, and they found this machine is slightly better than that or this. Then you use it. It's good for healing because of what we've talked about, how actually platelets is important in healing. So yeah, I won't bother you with this, how to handle it, or yeah. It's not difficult. No. It's for you. It's like a breeze. It's like a walk in the park. It's easy. لأنه most of the private clinics, nurses are very good too, but they are not experienced. يعني they come, يعني in 1 week, they know how to do it. You just have to know how to extract blood. That's all. How to use a machine to plug it. It's easy, very easy. الفكرة إنه you have to know when to inject it and before it gets coagulated. لأنه blood will coagulate, صح, will form a clot. Yeah. It stays anticoagulated for 8 hours. So, anyway, so it's used in a lot of areas. Now we use it in cosmetic procedures. طبعا we use it for facial plastic surgery. Is for facelift is proven and is very good. It reduces hematoma, it reduces seromas. For blepharoplasty is used and chronic wounds. The chronic wounds في studies عليها كثيرة. طبعا you will come and find studies that support, studies that don't support, and there is no single modalities like you all talked about that's 100% will work with every patient. But and that's why we have to have different modalities to هنا chronic wound بالذات الألسرز يستخدم في bone grafting and في orthopedic procedures as well. It helps integrate the bone, when you do bone grafting. Studies, just to let you know evidence from studies. There are small studies, retrospective. بس الأشياء اللي proven الأشياء الثلاثة هذه في studies. في facelifts proven إن it reduces hematomas. في bone grafts, mandibular grafts, improved chronic ulcers. When we deal with chronic ulcers, not with other types of wounds. So yeah, I think overall summary, mechanism, platelets release growth factors critical to wound healing. Preparation, PRP is generally generated by a blood draw, centrifugation, and then activation. Application, it shows a lot of promise in soft tissue repair and bone grafting. There is preliminary results that are positive, but we need more studies, of course. PRP is valuable to plastic surgery and to wound healing with potential to improve outcomes. And if you have it in your clinic and it's easy to apply, it will even reduce the cost. Thank you very much. Any questions?
Thank you, Dr. Abdullah. Dr. Abdullah is welcome to have this training for the plasma exchange. Thank you, Dr. Abdullah. Now we can know when we can call the plastic. Not always we are doing dressing all the time. We should stop the dressing and consult the other departments. Let's take 15 minutes coffee break, then we will continue. Thank you.